the oncology talk, and Josh Meeks and myself will be speaking today about some articles that we think are important for the treatment of bladder cancer. Some of these articles are relatively new, and many of them are over the course of the last decade, I would say, that at least help me, and I think most of us kind of will help kind of tell us why we practice the way we do. Next slide.
These are.
I do not have any disclosures. Dr. Meeks has disclosures. I don't know, Josh, do you have to say something, or do you just have to list them here?
No, I think that, again, this will be given in an unbiased fashion, but just to acknowledge, that I do have some disclosures today.
Great. So, just to briefly go over really why we're here. What's the scope of the problem? Bladder cancer is, is about 80,000 new cases diagnosed per year. And it is one of those things that can lead to significant morbidity and not insignificant mortality, depending upon the grade and stage by which the disease presents. This is Karim Chamey's work from not quite a decade ago, but that really shows people with non-muscle invasive bladder cancer. On the top curve, you see recurrence rates. Recurrence rates are the rule, not the exception. And if you live long enough, you're highly likely to have some degree of recurrence on upwards of 70%. Progression rates are not insignificant as well. About 1 in 3 men, 1 in 3 people who present with clinically localized disease over the course of the first decade of life, or the next decade of their life, will progress to a higher stage. And mortality, about a 10% or 12% mortality rate at 10 to 15 years. So, next slide. So we wanted to go over our talk, or go over some articles. Some of it will focus on localized bladder cancer. Some of it will focus on upper tract, and some of it will focus on the treatment in the perioperative setting of muscle-invasive bladder cancer. So next slide.
Yeah, so I think probably the most important update, or one of the most important updates that came in 2016 for non-muscle invasive disease, is enhanced cystoscopy. And it doesn't really matter whether that's with narrowband imaging or with Cysview or blue light, which you can see here. I think the key thing is that if we just depend on white light cystoscopy, there's a lot of bladder cancers that we're missing. So I don't think that the surgical training is evolved per se, but our technology is evolving, and that really isn't captured in the update to the guidelines. I'll tell you that almost every primary tumor I resect, I'll use blue light for that. I don't know about you, Dr. Kundu, but I know that certainly in patients that have positive cytologies without visible lesions, I definitely think it increases what you see and certainly what you biopsy. Maybe half of what you biopsy may or may not be real, but I think enhanced cystoscopy certainly changes how you do the TURBT. What are your approaches to blue light, and when do you use it, Dr. Kundu?
Yeah, I try to use blue light when I can. I think not yet in the office here, but I do think there's some, if we're trying to maximally debulk patients for preparation for intravesical therapy, I think blue light is an important adjunct. Because really the intravesical BCG therapies and really are meant to try to prevent recurrence or really treat CIS. And the better you do at your initial TUR or ablation or resection, the lower the likelihood of recurrence. So I think that's really what this has potentially helped us do, is try and avoid recurrences, which would maybe help us keep us away from the BCG refractory state if possible.
And I certainly think in a training environment, you'd be surprised how many lesions we miss when we go from white light to blue light. So I think it's almost a no-cost move to do that. You brought up a good point about flexible blue light, and it's interesting. So this paper actually is a little dated by now. I think it was actually originally published in 2018 on flexible blue light cystoscopy, 300 patients in the blue light registry, and really. Unfortunately, I don't think this technology has made it into day-to-day practice. To my knowledge, there's only one practice in the city that has flexible blue light. I think part of it is a machine-based issue. You know, in Europe, the agent Cysview is decoupled from the hardware. Here, the hardware has to be Karl Storz, and it's a pricey tag. I mean, it's, you know, around $50,000 to purchase the equipment that you need to do flexible blue light. And then I think the challenges are to trying to which patients get it in clinic. I mean, theoretically, almost every patient could benefit from it. So picking the patients and identifying those at highest risk for recurrence kind of adds some bulkiness to the clinic. But this is the data that supports it. Again, 300 patients. The key thing is that 13% of them had tumors that, you know, showed up, or 13 tumors, or around 20% had tumors that showed up just on blue light on flexible cystoscopy. And again, many of those tumors, you know, 21% overall, were CIS. So this is going to definitely change how if we implement this, if this becomes routine. When you think about that, that's almost 1 in 5 patients that would go from being visibly normal to having tumor. So that could completely change how we group patients that we see. Like literally 1 out of every 5 would be put in a different category from recurrence or non-recurrence. So I think this technology is great. I think it would be great to use it, but again, the implementation still needs to be sort of carried out. And I think there's the data seems good, but it just needs to be done better.
So one of the things that we do for the surgeons that treat bladder cancer, or the physicians that treat initial bladder cancer, is we will often give intravesical chemotherapy immediately after our TUR. So I wanted to go over SWOG 0337, S00337, which is a few years old already. But this was a really nice study out of the SWOG group, which really just randomized people to getting gemcitabine or saline. So previous studies historically have looked at mitomycin C and epirubicin and have shown efficacy in terms of preventing recurrence. But as most people know here, we do use gemcitabine for the treatment of really locally advanced or metastatic bladder cancer. So what this study did was looked at, it was a randomized study taking patients who had suspected low-grade cancer. And those patients who were suspected to have low-grade cancer, they were taken for a TUR and resected to completion, and then they were given an immediate intravesical dose of gemcitabine versus saline. And what essentially that they found was all patients were thought to be low grade, and overall there were 416 patients accrued to this study, and of them about half got saline and half got gemcitabine. And what they found is, looking at the overall group, is that there was a reduction of recurrence the hazard ratio was 0.66 in terms of reducing recurrence by all patients. Now, when you're doing a TUR, you don't necessarily know whether it's high grade or low grade. So when you looked at recurrence just amongst the low-grade patients, they did a subgroup analysis looking at high grade versus low grade. If you looked at the low-grade patients, what happened is you saw that the risk reduction was about 50% in terms of having a recurrence. But the high-grade group, the risk reduction, the hazard ratio was 0.8, but the confidence interval crossed 1. So really what this showed was that in patients with suspected low-grade cancers, gemcitabine, which I would argue is probably one of the new standards in the treatment of this disease process, is effective at reducing recurrences for the treatment of bladder cancer. I know this is something that we've struggled a little bit to get, but we now have it here at Northwestern. But I think it really highlights the fact that an immediate intravesical utilization of an intravesical agent here, specifically gemcitabine, you can see on this next slide, the difference in reduction of saline versus gemcitabine does reduce the risk of recurrence. And one of the things they say here is that bladder cancer, as we all know, is expensive to treat. So while it doesn't necessarily impact progression, which is obviously not common in low-grade cancers, it may actually reduce future burden of treatment for the patients in terms of recurrences. In this group, there was no grade 4 or 5 events. In fact, one of the reasons why I think gemcitabine might be more more appealing than mitomycin is that one of the main benefits of gemcitabine tends to have less irritative symptoms. So we really hope to be transitioning to this here at Northwestern very shortly.
Yeah, that's great. I mean, I think this becomes, again, like you said, potentially the standard of care for post-op chemotherapy. And you could actually potentially extrapolate this data for treating intermediate risk disease in the clinic that's low grade and recurrent, that you would, that this could actually be a very effective therapy. And so I think most of us are probably considering GEM for intermediate risk tumors, largely based on this SO337 data.
So I have this next slide looking at one of the reasons that I wanted to present this is, as we are suffering through a BCG shortage, or really our patients are suffering through a BCG shortage. Why do we use 3 years of maintenance BCG? And this was a study that's old. It's got 20 plus years old now, run by Don Lamb. And what this study did, published in the Journal of Urology, is what they did is took 660 patients with a high risk of recurrence. So what's interesting within this randomized study is that they took patients who had at least 2 high-grade recurrences within 1 year, or 3 high-grade tumors within 6 months who had not initially seen BCG. So that's kind of a enriched population for high-risk disease. And every one of these patients underwent induction BCG. So they underwent 6 weekly treatments of BCG, but then were randomized to either no maintenance or 3 years of maintenance via the schedule that we often use, 3, 6, 12, and every 6 months for up to 3 years. Next slide. And I think this is kind of the crux of the article here, which is what I wanted to include. The 3 Kaplan-Meier graphs here represent, on the left, recurrence-free survival, progression-free survival, and I believe death and overall, cancer-specific survival. And what you can see here on the left is, in the absence of maintenance, there was a significant reduction in terms of the median time to recurrence from about 77 months to 36 months if you did not use maintenance. And this is for 3 years. Looking at both progression-free survival and survival, you can see that the curves do diverge. But actually, at the time of the reporting of this article, the median had not been reached for the for the maintenance group in terms of overall survival and progression-free survival. And it really just does show, this is one of the reasons why, barring the shortage, that we really use 3 years for the patients. And we're going to show our article in just a little bit. You can see the recurrence rates are high here, but this is likely because these patients were enriched for having high-risk tumors. But I think I wanted to present this article because it presents kind of one of the hallmark or landmark articles as it relates to why we use 3 years of intravesical maintenance therapy.
I mean, it's really a classic. I will say that it's interesting when you read the paper, only about 13% of patients actually completed the entire 3 years. So, you're certainly seeing the benefit, but I think, one of the caveats is that there are very few patients who make it all the way. So, clearly if they can get there, that's great. But, by and large, like, was it 1 in 8 actually is able to go the full 3.
So I think I'm going to do this one as well. So, now that we've had the BCG, now we're in the midst of the BCG shortage, that question has been answered in the past, or at least tried to be answered, in terms of whether you can use traditional dosing, whether you can use 1/3 dosing. This is the study out of the EORTC, I believe published in 2013 or 14, where they tried to answer the question, do we need to use full dose BCG for 3 years, or can we use reduced dosing, 1/3 dosing for 3 years, or can we use full dose for 1 year, or can we use 1/3 dose for 1 year? So this was a very large study accruing, boy, let me see here, I think 1,800 patients. And what they did is took patients, not really enriched per se for the high-risk group that what I just mentioned, but what they did is randomize them to either get 1/3 dose for 1 year, full dose for 1 year, a third dose for 3 years, or a full dose for 3 years. And really this was designed as a non-inferiority trial, looking that the results by using the reduced dosing would not result in a worsening of a non-inferiority of less than 10%. Next slide. And there was a lot of slides on this, but the bottom line is that when they looked at their groups, these are the Kaplan-Meier recurrence graphs of all 4 groups, and the green here represents the patients who got 3 years of full dose, and then right above that is full dose for a year, 1/3 dose for 3 years, and the top most recurrences happened in the 1/3 dose for 1 year. So essentially they conclude across their study that the use of either shortened dose BCG or reduced dose BCG was not non-inferior to the use of full dose BCG for 3 years. So really what this did is answer and why we still practice, if we had enough BCG the way we do in terms of having enough BCG for 3 years. What they did notice though, however, as you can see, the graphs are not wildly divergent. What they did notice that there was no increased risk of progression-free survival within this group or death from this group. So they did, next slide. What they did mention though here is that when they did subgroup analyses, that actually for intermediate risk patients, and as you all know, we practice kind of our BCG schema now, giving it to patients with high risk, not giving it to lower intermediate risk patients. And while their intermediate risk schema was slightly different, what they did find is that the patients with intermediate risk, they thought did well with 1 year of full dose and did not need the full 3 years of dose, whereas the high risk patients benefited from a full 3-year dose. Next slide. So in conclusion for this particular study, and I think Josh will talk about some of the updated data as relates to reduced dose BCG, intermediate and high-risk patients after TURBT, there were no differences in toxicity, interestingly, between a third dose and full dose. As Josh said, there were still a lot of patients that discontinued, but it was not different based upon the amount of dosing that you got. Intermediate risk patients did as well with a full dose for 1 year, but high-risk patients did better if they got a full dose for 3 years, and it reduces the rates of recurrence. But there were no differences within survival or progression, and one of their comments was that using extended dose BCG or a full 3 years should be weighed against the benefit, cost, and availability of the medication for the patients.
Yeah, and that's a critical study. I mean, I think that sets the background. It's a huge trial. In GU ASCO, right before the world changed, the Nimbus Trial was presented. This is a trial in the Netherlands. And the main question here is in high-risk patients, and again, most of these are T1s, and looking at around 175 patients in each arm, can you de-escalate the amount of BCG? So it wasn't quite as clean as Shome's stop at 1 year, stop at 3 years, but the question is if you could basically decrease the amount of therapy. And so, and this is a little bit more of a modern update. So the patients got a TUR and a re-TUR, hoping to decrease the amount of burden of therapy. And then the treatment, the standard of care was clearly, they got BCG induction weeks 1 through 3, and then they got maintenance, weeks 1 through 3 at 3, 6, and 12 months. So a total of a year of therapy. The comparator arm just reduced the dose from 15 to 9 doses. So their induction was week 1, 2, and 6. So they got half the amount of induction. And then they got maintenance at weeks 1 and 3. And then they got that at the same frequency of 3, 6, 12. Again, we're not talking about a huge difference, but 6 doses are different. And the DMC stopped this study. The hazard ratio was 0.4. And the authors said that, clearly this suggests that, patients, at least with high-risk disease, have a higher risk of recurrence. Now, I think the key thing about this is that even though the rate of recurrence was significantly greater at reduced frequency of BCG, the rate of progression was still very low. So only 2% progressed, and that suggests that, you know, you're still ahead of the game. You can still salvage these patients, potentially by giving them either a different form of therapy or potentially reinducing them fully. I think it's hard to say, you know, why is this difference so striking? My gut sense, and again, it'd be very interested to hear, you know, a lot of folks who have a lot of experience with BCG, why it is, but my gut would be that the induction is probably the most important. And the fact that you're only getting 2 doses at induction, I think that really matters. And it may not be the maintenance that's as critical, but I really think those 6 doses to really kick that immune system in, that's probably the most critical part to this. But again, Nimbus tells us that, you know, the amount of BCG we give tends to be a pretty critical thing. Any thoughts on this, Dr. Kundu, at all?
Yeah, I think I agree. I mean, I think what we're garnering from both these studies is that the high-risk patients need the BCG.
Right.
And so I think that's why it's critical for risk stratification. For example, you know, if you have a high-grade TA that's small, you know, really consider that patient an intermediate risk patient. So you can reserve the BCG for the patients at the highest risk of recurrence or progression. So, you know, I think a lot of patients are disappointed. I'm sure all of you guys have, you know, dealt with these patients who kind of are expecting 3 years or would like to do it if possible. Not everybody's able to make it. And we've had to have some tough conversations with patients to say, really, we really need to reserve the BCG for the patients at highest risk for needing it. So I'm sure all of you have gone through it. We certainly have gone through it. But I think this highlights the fact that high-risk patients need the BCG.
You know, and hopefully the answer to this, there's a couple things that we think are going to change the landscape of this. Number one, you know, Merck is committed in the fall to ramping up their BCG after the fact that it's, you know, been made the same way for over 100 years. They're going to ramp that up. Again, hopefully, you know, the SWOG 1602 study is closed. We have another, you know, potentially 2 years left before the data's out for that, but the CIS population may be available earlier. So, you know, hopefully we'll have some answers that will change the supply of BCG, and which will really have a positive impact for our patients. I think I put myself down for this, but you know, either one of us can talk about this, Dr. Kundu.
Yeah, I'll talk about this because
Sure.
I think one of the things that I think we struggle with is what do we do with patients who have failed BCG? We all know that bladder cancer is a disease of competing cause mortality. Obviously, early recurrence after BCG failure is a worrisome sign. But, and we haven't had a lot of therapies really up to this point that have been all that great at reducing the risk of recurrence or specifically progression. But there has been data in terms of both gemcitabine, which seems to have a reasonable about 35% 2-year disease-specific, recurrence-free survival. And I wanted to include this trial, although it's not prospective. It takes a group of bladder cancer experts, and Mike O'Donnell really has led the charge for this. And what they did is compiled 276 patients who failed BCG. Now, granted, this is a retrospective review. Knowing that the gemcitabine patients do reasonably well with a 35%, 2-year recurrence-free survival, they added docetaxel. So if gemcitabine is good, hopefully gemcitabine docetaxel is better. And so what this is, so these patients all got induction gem-dosi. And what that means is the patients got a catheter. Some of them got bicarb, sodium bicarb the night before because gemcitabine is quite acidic. I think the pH is around 2.5. And then the gemcitabine dwells in their bladder after, I believe, 60 minutes. And then it was drained. Then they were given the docetaxel and the catheter was removed. And they were told to hold it in for about 2 hours if possible. All of these patients after maintenance, after induction, it was up to the discretion of the provider whether they got a maintenance or not. Next slide. And really what it showed was that the 1-year recurrence-free survival using this combination approach was actually pretty good. It was about 60%. And 2 years, I think the median follow-up for this study was about 2 years. But at 2 years, the recurrence-free survival was almost 50%, which I don't know if we're going to present some of the, I don't believe we're presenting some of the intravesical pembro, or sorry, systemic pembro for local recurrence, but it actually does better than that. And we don't know the long-term outcomes, but we all have the patients in whom you're just trying to buy time and to see if a lot of these trials, all of these studies really, while bladder cancer specific outcomes are important, age is a factor, competing cause mortality is a factor. So if you can render some of these people, half of them, recurrence free, then maybe you've bought the time that you need to try to avoid a cystectomy, which I think is important. And I've had some, I was a skeptic of this at first, but I've had some pretty good results in some people that I was sure would need cystectomy, and they're done okay so far. What are your thoughts, Josh?
Yeah, I mean, quite honestly, the data is very strong. I give Mike O'Donnell a ton of credit for this because he kind of started this. The SWOG did a 1 year, like it did a phase 2 with Jim. And again, the response was around 25%. McKiernan did docetaxel and it was a little better at 30, but this is amazing. You put two together and it's, there are some caveats that I have concerns about, right? So the fact that this is non-randomized, this is all just prospective data collection. There's no uniformity with maintenance and how it's given. I think the other thing that's weird is that there's not a difference between papillary disease, between BCG naive disease, BCG unresponsive. They all have the same data, which is a little funny, right? You would generally think that BCG unresponsive cancer would be a little bit worse outcomes, but if you look at their data, it's all the same, which either means it's very effective because the bladder hasn't seen 2 chemotherapies before, or it's working in a different mechanism, or it's just hard to put together. But I tell you, you're right. Most patients do really well, and I think it's a go-to. Again, the only other challenge is people have to have enough, compliance in their bladder to be able to hold it for. I generally try and go an hour and a half for each drug. So, you have some people who have just terrible CIS or terrible BCG cystitis, and they can't hold it longer than 30 minutes. I'm not sure it's as effective. So that would be the only downside to it. And again, upper tract disease. But again, I think this is great, and it's a shame that it's not more sponsored by pharma, and it's going to be hard to compare it to some of the therapies we're going to talk about coming up. I think this is just one last slide on that.
Yeah, I think this is just outlining the fact that the CIS patients tend to do a little bit worse, and this is not unlike a lot of the other data that we have, that if you have a papillary tumor plus CIS, or really any CIS, the recurrence risk is higher. So, but I think it's a good option for the patients who are really refractory or not candidates for having a cystectomy or reticent to have it as a second line option. And my take on it specifically, Josh, is like we do, for metastatic disease or neoadjuvant disease or neoadjuvant chemotherapy, we do GemCis or GemCis, and then we do IO afterwards if necessary. Yep. I mean, I guess the BCG is the IO up front, and if it fails, then you do chemotherapy. And we know there's differential response with different people. So it's kind of the reverse order here.
Yeah, so this is the trial you were talking about, and again, this started around 2014, right when the original checkpoints were coming out. So this is Keynote 57. It's a phase 2, and the thought here is, if you take BCG unresponsive patients, it's a single-arm phase 2, looking at, if you give patients pembrolizumab that are BCG unresponsive, how do they do? And it's pembro given every 3 weeks. And the primary outcome was at 3 and 6 months, and the goal was to see how long you could, maintain disease-free survival. There are, again, 2 cohorts. Cohort A was largely with CIS, was completely with CIS, with or without papillary disease, whereas cohort B, which has not been reported, was papillary disease alone. And that's been reported in many places. This is the most updated data, and the challenge is that, Pembro's gotten FDA approval based on this. The paper's not out, so it's a little bit hard to know how to completely, care for these patients if you try to treat them in this manner. So, generally what I think is that if you look at the data, the patients had to have a CR by 3 months. And if they didn't CR by 3 months, they were off therapy. And then they got evaluated again, 3 months later at 6 months. And again, if they didn't have a response, they were off therapy. So they have to have a negative evaluation and a negative cytology. I think that the reason really, if you look at the overall response, and this is kind of where I included this, because you find very few abstracts that actually talk about who made it to a year, and it's not great data. It's around 20 to 25% made it to a year of therapy. But I think the key part here is if you look at the Kaplan-Meier, these are the responders at 3 months, and the durability is very good. So if you made it to 3 and 6 months and you had a response, your chance for durable response is very good. So, again, the key would be the response seems good if you respond. So it's almost like a lotto ticket. The other part that they just presented recently, I think at ASCO 2020, was the rate of progression was still very low. So, you may have a positive cytology, you may not be completely cured of your CIS, but your progression to metastatic disease is low. So again, I tend to think about it for patients that are T1s. The other thing I think about are folks who have upper tract disease that are BCG unresponsive, because getting BCG or getting gemdosi up to those tracts is really challenging. So this is the way to treat those patients without having to worry about a topical application. The other thing the other drug in this space, which really changed over the last year, is netafergine, which would commercially known as Adstiladrin. And the single-arm phase 3 randomized trial was just published last year. And again, very similar population of patients. I'd say that this is kind of a landmark study for BCG unresponsive disease because it really helped us identify who these patients are. And again, the primary endpoint was a complete response in this population, defined as a negative cytology and a negative biopsy. Unlike Keynote 57, at the end of a year in this study, the patients had to have a negative evaluation in the operating room. So they had to have, or at least a negative biopsy rather. So they had to have a negative tissue result. And that changed the response rate by about 15%. So, the way this is done, and again, one of the benefits of this therapy, I think the reason that it's really worth considering is that it's not a ton of investment from the patient side. So they got Adstiladrin every 3 months. So we're only talking about 4 doses in the bladder a year, which is really a very nice option for patients. They're not coming in 3 weeks in a row, 6 weeks in a row. In a time, when COVID was really bad and, patients didn't even want to come get their BCG, they would get a dose every 3 months. So that's a real benefit for the patient that, every 3 months, and then they only have to hold it for an hour. And so this is the trial. Again, a total of around 200 patients were enrolled. 100 of them were CIS plus or minus papillary disease, and then there was around 50 that were just papillary alone. This is the results of that. And again, this doesn't include the group that had, the end of study biopsy, which again reduced it by about 15% to a total of 30%. But this is just by visual evaluation. They got to 45% complete response at 12 months. Again, the blue is the CIS plus or minus TA, and the purple is TA alone. So I think this is a positive study, and again, a really good outcome for Adstiladrin. This is the cystectomy free, and again, this is kind of changing the rules about how we report an outcome. So about 25% of patients had to go on to get a cystectomy, and again, if you look, 29% were in the CIS group. If you had a response at 3 months, your chances of needing a cystectomy are significantly less in this group. So it's not only keeping disease away, but keeping people from life-changing surgery. The tolerability is really very good here. You can see that there are some toxicity that was, but most of these were low-grade events. If you look at the grade 3 events, it was less than 1.3% or so of the total population, and most of this was bladder spasm. So this is given very infrequently and very well tolerated. I think the major challenge to this is why isn't it FDA approved yet? And there's something going on. Unclear what that is. So this is sort of hitting the kind of biopharma world as far as why we don't have a therapy in hand by now, and why is the FDA not approved it? I don't have an answer for you there, but I would think, given the data that it was presented over a year ago, even with everything that's happened in the world, the anticipation was that you would have seen that, but it's just not there yet. We're going to transition to radical cystectomy. I'll present the first little bit, and again, this is a paper that was presented about a year ago, and it was asking the question about pelvic lymphadenectomy. And from the times of Halston, we all believe that the more surgery you do, the bigger the operation, the more lymph nodes you remove, the better the patients do. And there's a lot of retrospective data to suggest that. So you can see, on the slide, the yellow line showing more lymph nodes, the patients do better. That older sort of, I think that's a Harry Hurst study in the middle, again, showing that if you took out more lymph nodes, the patients had better survival. And, whether you're lymph node positive or lymph node negative, there's good data that this makes sense. There's even, some retrospective data shown over on the side here that if you had an extended node dissection, patients do better. I think the hard thing here is, number one, there's a lot of bias in this data. In general, people who've had, I don't want to hypothesize, but people who've potentially done more surgery, more training may take out more lymph nodes. There's also a belief that it, again, assumes that there's no lymph node skipping. So this trial was a German trial, a randomized trial of patients around, powered to be around 400 patients, where patients were randomized to either a limited versus an extended node dissection. And what that looks like is, this is the limited dissection, sort of right at the pelvic brim, right, stopping where the iliac, where the ureters cross. Where the extended went much higher above that, went up to the IMA, it went lower than the obturators. Now, I think the key part to this in the trial design was that it assumed a 15% improvement in recurrence-free survival at 5 years, going from 50 to 65% with an extended node dissection. So that's how the trial was set up. The data suggests the trial was actually negative. I think a lot of that was due to the power and how the study was designed. So if you look at what they found, they actually hit that 65% recurrence-free survival in the extended node dissection. The challenge is that in the patients who got the limited, the recurrence-free survival was 59%. So they actually did better than you would anticipate. To get there, they would have, based on, if you would have had this data when you planned it, you would have needed over 2,000 patients to really do this trial accurately. There were some other things that were a little funny about it. Again, that there were a higher number of nodal events in the limited dissection, 56 versus 44. So you had more lymph node metastasis in the limited events. That kind of messes everything up. There's actually a higher rate of N2 disease in the limited study. So that's a little bit funny. Not surprisingly, there was a higher rate of lymphoceles in patients that had a greater dissection. Now, if you look at the overall survival, there's a trend there, and maybe when that data matures, it may get there, but I don't think you're going to see a budge on that. Probably the most interesting part to this is the S1011 study. So that closed over 2 years ago. We're actually not that far from having data on SWOG 1011. Why do we think that's going to be different? Well, it's a bigger study. There's 620 patients that were randomized in this study. They actually looked for a 10% difference in 3-year recurrence-free survival. So it may actually hit that if we get the same outcomes. Whether the surgeons were all credentialed, so there may be a little bit of a difference there. But I'm really excited to see if our SWOG study will cross the finish line and show a difference. I don't know. Did this change the way you approach lymph node dissection, Dr. Kundu?
Yeah, I think it depends. So I tend to do more of a limited dissection personally. I tend to go up to the common iliacs, but I don't go up in the para-aortics or paracables all that frequently. And that's just my personal practice. I know I think the outcomes are a little bit harder, and frankly, it's a little bit harder to get up there. So I tend to do, I guess, a little bit of hybrid of both. But I know, for example, where we trained, many of our surgeons would go up to the IMA, but I tend not to go up that high. But no, I still do I guess, some hybrid between a standard and an extended.
And I think that's what the data shows. I mean, to me, it suggests that do a node dissection, but you don't need to hurt the patient trying to do extended nodes, or at least that's not the standard of care. So again, I think it'll be interesting to see what the 1011 study shows.
All right, I'll talk a little bit about the RAZOR study. What this study is, it's a busy slide, but the bottom line is we haven't done historically a great job in understanding the difference between robotic and our traditional open surgery. Obviously, radical cystectomy is a complex operation with extirpative surgery, lymphadenectomy, and then reconstruction. So Deep and Parik really did a nice job in terms of putting together a multi-institutional cohort of patients that were randomized to who were candidates for cystectomy, that were randomized to get a open versus a robotic cystectomy. And I believe all these patients had extracorporeal diversions. And I'm not going to belabor the point here, but the bottom line is what they were looking for is that it really designed as a non-inferiority trial. And the top right here represents exactly the result, where robotic surgery was non-inferior in terms of progression-free survival. I think one of the things a couple of things that are worth noting amongst this busy slides, what robotic surgery did is significantly reduce blood loss, and the median blood loss was significantly less in the patients who had robotic cystectomy. And I believe about 45% of the patients who had an open cystectomy needed a blood transfusion. It was significantly less in terms of the patients who underwent robotic cystectomy. Next slide. Yeah. And so I think really one of the critical elements was that really everybody was hypothesizing that really bladder cancer is different. It's different than prostate cancer, it's different than kidney cancer, recurrence rates are high. But really, this was a really nicely done prospective evaluation that really showed that there was not a significant difference in recurrence-free survival or progression in the patients who had robotic cystectomy. Node counts were similar, margin rates were similar. The 5-year outcomes were also recently reported, and the results are pretty similar in terms of there were no differences between their initial reports. The only thing is you could say within the recurrence group, where this green box highlighted here, is that some of the recurrence sites, for example, abdominal wall, were slightly different in the robotic group. Port site recurrences and whatnot may have been slightly higher, but I think this is a really nice study outlining how the surgical management and the shift in many of the things that we've done, for example, in prostate and kidney, which we really have never studied in a systematic fashion, at least to those disease states. This answered that question, that robotic cystectomy seemed to be equivalent in terms of its outcomes and does offer some advantages of reduced blood loss for those patients.
Right, and I think the key thing is do a good job, right? Whether it's open or robotic, the technique, shouldn't dictate how you do the operation. Just do a good job, and that's the key thing with this.
Yeah, and I think we all have patients that, for example, if I'm doing a neobladder, I tend to do it open. If I have somebody who's, obese, I think there are significant advantages to doing a robotic surgery in terms of that posterior dissection. I think, Josh, as you say frequently, I don't have the patience to do the intracorporeal diversion, so I tend to do those open. But I agree with you. Do a good job, and I think if you can do a good job with either approach, or do the approach that you're most comfortable with and that you can offer the patients an effective operation.
So I think a critical part to figuring out, managing patients with muscle invasive bladder cancer is, what do you do with bad disease after cystectomy? And we all believe that there's got to be more we can give patients that don't respond to neoadjuvant chemotherapy, or, for example, the randomized trial data never really supported adjuvant chemotherapy in a way that neoadjuvant did. So again, we all believe there's got to be something we can do for patients, and this is really where this comes in. So this is IMvigor010. This was a randomized phase 3 trial of patients that were either previously treated with neoadjuvant chemotherapy or were platinum ineligible after chemotherapy. Again, 809 patients, prospective trial, and the primary outcome was disease-free survival. And unfortunately, this data didn't demonstrate a benefit in a year of atezolizumab after cystectomy. I think the key thing to kind of highlight here is that if you look at the disease, those curves, you definitely get separation of those curves, but unfortunately the curves roll back together at about 12 months time when you look at the recurrence data. Again, they only got 12 months of data, so 12 months of therapy. So would those curves have stayed apart if they got more? I think it's really too hard to say. And if you look at the survival curves, they'll split after a bit. So, unfortunately, this data doesn't really demonstrate a benefit. Now, I think there are some caveats because we're going to next go on and compare that to Checkmate 274. But the key thing about this was a trial where people were randomized to adjuvant atezolizumab versus, standard of care, which would be just surveillance. There was no placebo involved in this. So, if you look at the recurrence data in the placebo or the observation arm, that was 16 months was the median time to disease-free survival to recurrence versus 19. So kind of remember those numbers because we're going to come back to them when we get to Checkmate 274. I think probably the interesting part of IMvigor010 that really is kind of taken things to a new level in the biomarker world is trying to identify which patients may actually benefit and then which are potentially cured. And that's really where the ctDNA story comes in. So this is using the Natera platform. And if you look at patients that are ctDNA positive after surgery, overall pretty balanced in each arm. So there was 99 patients that were ctDNA positive in the atezo, 79 in the observation arm. Once again, suggesting that there's fewer patients with aggressive disease in the observation arm. But if you look at those that went from positive to negative, during the treatment, that was 18% in the atezo arm and only 3.8% or just 3 patients in the observation arm. And so if you look at those Kaplan-Meier curves for disease-free survival, obviously if you go from positive to negative, you do better. So the hazard ratio is 0.26. So really it's suggesting that if you're positive after surgery, you're at very high risk for recurrence, but those are the patients who are most likely to benefit from therapy. So I think this has led to IMvigor011, which is a randomized trial for patients that develop a ctDNA positive recurrence. So again, I think this is very exciting data about who to follow and who should get therapy. It may help us actually select for who's going to do better long term. I think we could contrast that data with the Checkmate 274 data. Very similar population, set up to be almost exactly the same. They got nivolumab for a year. The big difference is that the patients in this trial had a placebo they got at the same frequency. And this is the data. So again, showing a hazard ratio in the intent to treat population of 0.7 and a huge response in the PD-L1 biomarker population of 0.53. So this data looks very good. Again, this is disease-free survival. This is not OS, so in Europe this may not carry forward, but here I would bet that the OS is going to be real in the PD-L1 population at the least. So again, suggesting that if you get a year of nivolumab, it leads to better survival. And again, if you look at at some of the stratification here, there are some things that you should kind of take a look at. Again, if you got neoadjuvant chemotherapy.
It's all right, Josh. I think that was the last slide prior to our upper track stuff, right?
Yeah, that's right.
So sorry about the thing, but I think we had a couple of things of upper track, but I'm looking at our time and we're at 6:20. So I think perhaps that would be a good time, Mary Kate, or Ashley. I don't know if you're on the call, if you think that's a reasonable thing. I want to leave some time to answer any questions or go on any thoughts or comments that people may have. So maybe this is a good time to do that. Does anybody have any questions or any thoughts they'd like to share?
There's a hand.
Okay.
I just have a really quick question that's not really sort of cancer directed, just a question born out of curiosity. BCG is used throughout the world, right, to basically vaccinate people against TB. Why is there a huge problem with a shortage? Just purely out of curiosity.
It's different. The doses that you get in the inoculum for vaccination are a smaller ampule than what is done intravesically. So there's actually been people who've looked at taking and using that for intravesical delivery, and that's not unreasonable, but that's not what's FDA approved. The colony counts are different.
Dr. Ignatoff, I think you have your hand up. Maybe not. Dr. Ignatoff, do you have you're muted. Looks like you have your hand up.
Maybe he's waving.
Maybe not. All right. Well, thank you, everyone. We just wanted to give you a flavor of at least the things that we use to kind of treat bladder cancer patients, of which many of you obviously do participate in. And we wanted to really give you a flavor of why we do the things we do. Things have changed dramatically in all the disease states that we've done over the course of the last 10 years, and bladder cancer is no different. So I want to thank everybody for your time. And if there are no other questions, thank you all for joining us.
Nice job.
Thank you. Great job.